So seamlessly, another speaker from Western Sussex. We've come on a little day trip to the Big Smoke. Although I must say it was looking gorgeous when I got on the train this morning. I did want to stay by the seaside. The coveted after lunch spot. Please stay awake. I've got a few pictures that might keep you interested. I'm also very aware it's a mixed audience, so it's quite a tricky thing to talk about and to pitch to the right kind of audience. So if this is stuff that you know back to front, then that's good. If this is new, then hopefully something to think about for everybody. As Gavin said, I'm an anaesthetic consultant in Worthing. So one half of the trust that Pat has already mentioned, joined by the lovely A27. I'm mostly based in Worthing. And my main disclaimer is that I am not an expert by any stretch of the imagination on managing obstetric hemorrhage. I am a normal job-in anaesthetist with an obstetric interest. I spend usually 1 day a week on labour ward. I do an obstetric clinic, but it's kind of routine stuff. But unfortunately, these things happen all the time to everybody, sometimes unexpectedly. So even in a sort of relatively small delivery suite, we all have to be pretty on the ball in terms of obstetric hemorrhage, because it's not just one for the big centres. Okay. So I'm going to kind of scoot through a few things. I want to talk about why obstetric hemorrhage is a particular problem, or why hemorrhage is a problem in obstetrics. And a little bit about the challenges we face. And as I say, I work in a district general hospital. We don't have a lot of fancy stuff. We have fairly small departments, and we've got to work with the resources that we've got. So I kind of just wanted to explain what it's like from our clinical perspective on the ground. And for those of you that work in the lab, that's what happens to all your blood units. Once they've gone into the patient, they mostly get thrown on the floor so that we can then record them all. I'm sure if you zoom in, all the stickers are all perfectly done and everything's recorded. I'm not sure that was one of mine, so if not, don't worry. So the problem. So the midwives in the room and the doctors will probably be aware of this report. I'm not sure if everybody will. Embrace is our current way of how we report and analyse maternal death in the UK, and that is all maternal deaths, so all women that die whilst pregnant or within 6 weeks of birth get reported to this organisation. Each death is recorded and analysed, and there's a sort of quite extensive peer review process looking at all the care that the woman received, what happened, and whether any lessons can be learned. And they currently produce a report every year. The last one was in December 2016. But it looks at 3 years' worth of data, so it's a kind of rolling report. So the most recent data we've got is 2012 to 2014. And they now tend to concentrate on a couple of, or 2 or 3 kind of key topics in every report. Hemorrhage wasn't featured in the most recent one. I think in the report coming out at the end of this year, hemorrhage is going to be one of their kind of special topics. So we'll probably get a bit more detail on current sort of standards in obstetric hemorrhage. But we still get the numbers. And we know that obstetric hemorrhage is the leading cause of maternal death worldwide, but luckily in the UK that's not the case, and we're obviously grateful for that. And the mortality rates have sort of stayed fairly static in recent years. In the last report, there were 13 direct deaths, but the important bit is that bit at the bottom, I think. So for all those women that don't die from their major obstetric hemorrhage, hooray, we succeeded, they're still alive. There's women who've ended up with hysterectomies. There are young women who've ended up with really quite severe life-changing injuries, prolonged stays in intensive care, all the problems that entails psychologically, emotionally, severe lung injuries, limb injuries. So there's an awful lot of things attached to this as a kind of big problem, not just the women that unfortunately die from it. So this chart, again from the Embrace report, just shows you the breakdown of maternal death. The dark bars are indirect deaths, so the big one there, and one of the big topics this year was cardiac disease. So we're seeing lots more pregnant women and women that have just given birth to their babies dying that have got cardiac disease. It's a big deal at the moment, so we're trying to work on that. Hemorrhage is somewhere down here, so these light purple ones are the direct deaths. And it kind of sort of lingers on this tail in most of the reports in recent years. So that's where it stands. For those who've got a little bit of rusty physiology or never knew the physiology, The big thing about pregnant women is they have a lot of blood. Okay, so their blood volume increases by 40 to 50% at term. So by the time they're heavily pregnant, if you were sort of 70 kilos to start with, you've got a blood volume of about 7 litres. And obviously this is all a good physiological kind of anticipation of birth. And the cardiac output, so the work that the heart's doing is increasing as well. But what it does mean is that you've got this stonking big blood flow to your uterus and your placenta. So if you're doing just purely from a mathematical point of view, women can bleed, and they can bleed very, very quickly. And I'm sure many of you have seen that. I'm not wishing anyone, to suck eggs. Definitions. Most guidance that you read and most protocols have a sort of similar numbers-wise in terms of what you define as major. The biggest thing in obstetric hemorrhage is that it's really hard to estimate how much a woman's lost when they've given birth. And there's lots of ways to try to kind of improve that in terms of measuring swabs and pads and changing pads and sheets quickly and really just getting good at it. But I think still we underestimate a lot. And also some women lose blood very briskly, and some women, when they give birth, it's a kind of slow, insidious process, and it's kind of trying to work out where you stand in the big picture. As I'm sure everybody knows, women don't necessarily display the signs of big blood loss until quite late on. So they compensate incredibly well. And that's one of the challenges that we face for the women that are having a sort of relatively normal birth in the room, that we're not that quick at picking it up. Probably a bit better in theatres because we're thinking about it. Okay, so at sunny Western Sussex, as Pat has already said to you earlier, we deliver between sort of 5,500 women every year across the 2 sites. And now I just wanted to pull out the data of the number of hemorrhages that we're dealing with. So for those of you that are working big units with, 6, 7 more thousand deliveries, these numbers are obviously smaller. But I think it's roughly kind of similar throughout the region. I don't think we stand out particularly. But it's not huge numbers, really, if you think about that. So this slide from Embrace is really important because as part of the review, the peer review and the analysis of all the cases that they look at when women die in childbirth, they analyse the care that they receive, and they classify it into whether the woman's received good care or whether there are improvements that could be had to her care, and whether those improvements might make a difference. And the worrying statistic on here, so this is all deaths, it's not just hemorrhage deaths, but they felt over the 3 years of the report, 183 women died. 76 of those women, so 42%, it was felt that if we'd managed them better, that the outcome could have been different, which is quite a big headline news. And actually, some of the hemorrhage stats are actually higher than that, probably more like 60-70% of cases weren't managed particularly well. And I think that is something that we all need to be aware of. Okay. That's just a way to forgot there's just a bit of blood on the screen. Obviously not someone working with a wristwatch and no glove on. This is nothing to do with my obstetric unit. Really just to get the point across, for those people that don't work at the front line and don't see patients bleeding, it's really not very nice when you see somebody bleeding a lot. And I'm not sure it ever really gets any better. I still don't like those major hemorrhage calls when we get them. Those feelings don't go away. And I think what happens is we're very good at putting the calls out, actually, I think, locally. But what tends to happen in our hospital, I don't know about where you work, half the hospital turn up. Yeah, like a paediatric cardiac arrest, everyone's in, and then, they're all there, everybody's there. But the biggest challenge that we have is the leadership, the decision-making, how we prioritise all the tasks that need to be done. And it's a big old list of things that we need to do when someone has a major hemorrhage. And we've got a lot of time pressure. So, I said, you've got this huge blood flow to the uterus and the placenta that you need to try and stem. And in addition to that, you're trying to catch up all the stuff you already lost. So, as an anaesthetist, I love a guideline. We always get guidelines constantly coming to the door, emailed out to me. This is an old guideline from the AAGBI, who sit just up the road, actually, important place. This was the original transfusion and the anaesthetist guideline, which was back in 2010. Kind of left it as on the slide because it's quite nice and red. There's an update to it from end of last year, which is sort of similar. There's a few changes in it, but essentially I just wanted to try to kind of convey, it's great having the guideline and we've all got hemorrhage protocols in our hospitals, and there's just gallons of lists of things that we have to do. So these are all the things, for those of you guys that don't work on labour ward, these are all the things they want us to do pretty much straight away. All of that stuff at the same time. And if you're thinking, you know, I've got 10, 15 minutes before this woman gets shocked, it's actually quite hard to delegate all these jobs to everybody. So you have to work really, really quite hard as a team to get all these things done. And then the next slide, I think, demonstrates that as well. So I'll talk a little bit about prompt, which is one of the training courses that we run where I work. I'm sure many of you are familiar with. This is the hemorrhage kind of algorithm that appears in the prompt manual, which I think looks lovely. And is a great thing to kind of, know about. But again, it's important that we get all these things done, but you've got to do, initially, you've got to do all of that straight away. So, yes, you need everybody there, but you need everybody to be working kind of well with the same kind of goal. And that's the biggest challenge that we have, I think, as senior clinicians, is trying to get all that stuff done. It's busy and there's lots to do, and you have to do it quickly. So just do that and that. So, when I was asked to do the talk, I said, what kind of things do you want me to cover? They said, could you do case history? Everyone likes case history. So I said, okay. So I've got a cracking District General Hospital case history for you. So Amanda is 29, and she attended to us in her 4th pregnancy. Some people in the room might know her or of her. And she's a really poor attender. She really doesn't. She presented at 30 weeks in this pregnancy. And we knew about her when she presented in her 4th pregnancy, because she'd also presented very late in her 3rd pregnancy, having had 2 normal vaginal births before. She turned up in her 3rd pregnancy, and I remember being called down to see her by one of my obstetric colleagues. She turned up at 36 weeks, and they'd scanned her, and she'd had an unstable lie. So the baby was in a sort of funny condition. Basically, she was going to end up having to have a caesarean section. And the reason they wanted me to see her is that she had something called Noonan Syndrome. And I have no idea if anyone knows what it is, but I will tell you. It's a congenital problem, a bit similar to kind of Turner's syndrome, but it can affect males and females, and it occurs in about 1 in 2,500 births. A little bit different from Turner's in that fertility is normal. 4th pregnancy, I didn't have to tell you that. And the heart defects that you get here are a little bit different to Turner's, so you tend to get sort of right-sided heart defects. So Amanda had open heart surgery when she was 2. She'd had a pulmonary valvotomy done. And she had a residual ventricular septal defect, so a little hole between the right and the left side of the heart. It didn't give her anything in the way of symptoms, and she was essentially normal from that perspective. She was rubbish at coming to hospital, so we didn't have a lot of recent investigations on her, but the most recent echocardiogram, so the most recent heart investigations, looked pretty good, actually. She had a little bit of valve leakage, but there wasn't anything that was that dramatic, so that bit was kind of covered. And the other things that you get with Noonan's is you tend to get kind of short stature, you get quite characteristic facial changes that you can see, you get learning difficulties, and for the anaesthetist in the room, you get a lovely looking airway. So she did have she not a great mouth opening and a kind of small jaw, but it wasn't horrendous. And so when we saw her at 36 weeks, 3rd pregnancy, which was, I think, only 18, maybe 12 months, 18 months before the 4th, they were very close together. We looked at her airway and thought, oh, okay, she doesn't look great, but she needs to have a caesarean section. So there she is. And in addition to everything, she's also got von Willebrand's. So we were like, hooray! So 3rd pregnancy, we saw her and had this, and we didn't have a huge amount of other detail on her. So I'm sure people are way more versed in dealing with von Willebrand's than me. in this audience, but obviously it's an inherited bleeding disorder. It's a bleedy one, not a clotty one, which is, they're my two ways of looking at things in haematology. A bleedy one, okay, this is what I have to do. And there's various different types, and from what I understand, it's very difficult sometimes to work out exactly what type's going on, certainly when someone presents 36 weeks pregnant, because your von Willebrand's factor tends to go up quite a lot in pregnancy, so it goes up early doors, and then by the time you're kind of third trimester, it can be 3-4 times normal. So she had, I think, most of her tests all looked kind of normal, in fact, were kind of supra-therapeutic. So at that time, the haematologist said, well, we don't really know what's going on and we don't really know underlying where we're at. We probably wouldn't stick a needle in her back if I were you. And we said, okay, we'll give her a general anaesthetic. So we did her caesarean section under general anaesthetic for her third caesarean, and it all went quite well. And actually, she wasn't that difficult to intubate. Her airway was okay, and we thought we'd nailed it. However, she got pregnant again. So when she came back to the fourth time, having had all that story, and she'd had her general anaesthetic, and we thought everything was fine, we were like, oh, it's okay, it's good. Maybe, all will be well. Until she had a scan that showed that she had a major placenta previa. Okay. Welcome to district general life. Okay, so she had a scan, so for those people that don't know, she had an abnormal implantation of her placenta, very low down, right down by the bottom of her, by her cervical os. And, hey, she had a caesarean section before, didn't she? Okay, so now we think that she might have placenta accreta, and that she's at risk of that, in where the placenta will then invade into the uterine wall and potentially disrupt the scar from her previous caesarean section. Going well. Going well. So, what do we do? All difficult. All difficult sections. Don't do on a Wednesday. Okay? So Wednesday morning is my labour ward morning. I very quickly made sure it wasn't mine. So, you know what, I love working in Western Sussex. You know what my biggest gripe is? Not being able to get the notes that I want to get subsequently. Yeah. So I wanted to go right back in and look at real detail of what happens during the fourth section. And I couldn't get the notes this week, so I'm cross from that. However, I've got quite a good memory of what happened. So in terms of the detailed planning, it's difficult because we had a lot of information about her. We knew a lot about her. There's only kind of so much planning that we could do. So we had 2 consultant obstetricians that were going to do the operation. We chose to do it in our normal delivery theatre, which isn't in main theatres, but we're fairly well kitted out. We had senior anaesthetic involvement, not me. But we did it on a Thursday, and I was called to help because Thursday morning was my office session, so I did end up involved, unfortunately. We had it was a planned general anaesthetic. We'd liaised with the labs in advance. We didn't have a lot that we could do from sort of hematological side, apart from tranexamic acid, which was obviously on our list of things to do. And we use, as I'm going to mention in a bit, we use cell salvage routinely in Worthing anyway, so the cell salvage was good to go. And so what happened? I wanted to give you a lovely timeline, but I couldn't get the timeline. She bled 7.5 litres in total. I spoke to the obstetrician who did the operation this week and said, remember that case? What did you remember when you were doing it? And I'm not going to repeat it. Ruth Mason, the language she would use. So she swore a lot. She bled a lot. Ruth swore a lot. Essentially, they had investigated, sorry I didn't mention, but when we were querying about the placental accreta, she did get an MRI scan. It didn't show, it wasn't really all that conclusive, which annoyingly, they're often not actually with placenta accreta, but we could have had a high suspicion of it, which really is all you can do anyway. Certainly, once they started the caesarean, they realised that it was definitely an accreta. So she bled early straight away, and they went in she had a hysterectomy almost immediately, was the plan that she was going to have it. And she'd been consented, and it was her 4th baby, and there were probably a lot of reasons for her to have it. So they went in early with that. So despite a very early decision to do a hysterectomy, she still bled lots. We did give her, I think, in total, I think it was about 10, 11 units of normal blood with 4 or 5 of FFP. She got 2 grams of tranexamic acid, and we transfused her back about 1,500 mils from the SelfService. So quite a reasonable amount that she ended up receiving. Once the hysterectomy was done, she was still bleeding a lot, so actually they packed her tummy and she went straight to intensive care, where they left her for 24 hours and then she went back to there to take the packs out the following day. So from a kind of hemorrhage perspective, it was big, normal big, but she recovered very well actually after that, and her intensive care stay was fairly short, which maybe only in for 3 or 4 days. And then she got home. That was her outcome. So there's your scary case. I just put this in. I'm sure most of you are aware of the various performers that exist. I'm sure you've got local things in your hospital, but not so much abuse in theatre, but I think certainly if you have major hemorrhage in the room, for people that are delivering, vaginal deliveries in the room, these types of documentations are really important, not only because it encourages people to make decisions quickly, so you've got things like, right, we've hit this, let's put the call out, we've hit this amount, this is now what we're going to do, make sure that you're contacting people. It's a good sort of aid memoir as you're going, because as we've said, there's a huge list of things that need to be done. But also it's great for audit and looking afterwards and working out what's going on. If you can get hold of the notes, then you can analyse what happened and look at your timeline. I just want to talk a little bit about training. This is a picture from one of our prompt courses that we run. For those people that don't know, it's Practical Obstetric Models Professional Training, which was developed down in the southwest with Tim Draycott and his team. He's an obstetrician down there. They've done loads of work. It's very interesting reading. They've got a very good website for people that are interested, looking at training the team. And actually, as it was devised, they looked a lot about where you deliver your training, and is it important to be in a kind of high, slick simulation environment, or is it okay to be in your normal environment, and low fidelity versus high fidelity. And didn't find a huge amount of difference in terms of how people felt following the training. But they've had some lovely neonatal outcomes in their data to show that actually they can improve the care of babies, which in simulation and a lot of the training that we do, it's very difficult to prove that we're making a difference. You tend to do training and people say, yeah, that was great, I feel really good and I feel confident, but it's hard to put that into clear numbers. And when you're then trying to justify to someone high up on the exec board of your trust why you want to spend money doing training, and you'll go, well, the staff feel better. Yeah, they're less interested. But if you can say that your rates of neonatal hypoxia and shoulder dystocia have been reduced, aka let's save lots of money for the trust because people aren't going to sue you, suddenly they're interested. Not that I'm cynical. So the way we actually run ours quite high fidelity because we've got some quite fancy mannequins and we like using them, and it's quite good fun. But it's something that we have started in the last couple of years. I'm sure you're running similar things in your units, but it was just to say hemorrhage is a really, really good thing to run in this kind of environment because there are so many people involved. I would love to be able to do one with a bit more involvement of our guys on the other end of the telephone and involve them, and they're all going, yeah, because as you know, one of the beauties of today is that you're getting to talk to people that you don't normally see. You maybe just speak on the phone, and having an appreciation for each other's jobs is very important, and it does certainly make for better care. So it's something that you should think about in terms of training. And I was going to just briefly say something about SelfService before we move on, which I think might lead into your talk nicely. It was just a coincidence. SelfService, I'm sure you've all seen the stands upstairs and things. In Worthing, we're I would say, lucky. Maybe people think we're a bit kind of crazy, but we've been using SelfService for all our elective cesareans, all our cesareans, since about 2002. I'm not sure anyone else in the region has been doing it that long. I may be wrong. The problem with SelfService is the guidance, all the guidelines you read about when to use it, how to use it, says, well, everyone has to be really well trained. You need a person who's really slick at opening it all up and turning the machine on and running the machine. And you should be using it regularly. Now, if you're working in a centre that does livers, that does lots of vascular surgery, then you'll be using it, I'm sure, all the time. We don't have vascular at Worthing anymore, it got moved. We now don't have our polytrauma patients, they get sent to Brighton. So we have fewer and fewer patients having big bleeds, certainly expected big bleeds that are coming through our way. So, what we need to do is we need to make sure that our ODPs and that our anaesthetic nurses are trained and happy using the equipment. So one of the great things about using SelfService for all our electives is that it's properly routine. It is just like putting a blood pressure cuff on. The SelfService machine just comes on as part of it. So when we get cases like that case that we had, who loses 7.5 litres, we don't waste all that time trying to set up, oh, where's the machine, where's the kit, oh, we need an extra person to come and run it, get so-and-so, they've been on the training course. We just don't have any of those difficult, tricky conversations, and we don't have the delay. We don't have surgeons that complain about the suction, because that's their normal suction. So that's also an advantage, because when you don't, the self-salvage suction is a little bit different, so when you're operating, it can feel a bit strange. We still, the 1 in 9 data is from a few years ago, but speaking to my colleague, who's David Uncles, who's really driven self-salvage in our unit, he says he thinks we're still roughly around there in terms of 1 in 9. The most we've ever infused back has been 3.5 litres, so it's pretty significant. We've got quite new machines, which are pretty slick, I have to say. They've been good, they've been well received. And what I mean by the first stage is, I don't think you might hear a bit more about it in detail, but essentially there's two parts to it. So one is the collection of the blood, and then is the second stage is the spinning it down, and then we're giving the blood back. So really what we do is we just do all the blood collection stage, so we don't have to open all the kits. So that keeps our costs down. I am reliably told that the last time we costed it all out, we were about cost neutral on self-salvage and Worthing. So it's not horrifically expensive, and in terms of what we gain for the big bleeds that come through from time to time, I think it's very useful for us. In addition to that, there has been a big trial that's going to report, I think the abstract has not long come out, fairly hot off the press, which is a trial called the Salvo trial, which was done in a number of about 25 units in the UK, obstetric units, and they were looking really at the use of routine self-salvage versus not routine self-salvage, and whether it actually does prevent the use of using donor blood. And the results of that look like there will be a modest result in terms of preventing the use of donor blood. I don't think it's going to be huge, but I think there's going to be, there will be a bit of evidence to show that if you're using it regularly, you can keep your transfusion blood down, which may not be groundbreaking enough for people to change their practice entirely if they're working in a big unit and they're happy with the way they're using the self-salvage, but I think will certainly give us, as a smaller unit, quite a lot of justification to keep doing what we're doing. It makes a lot of sense to carry on. As I say, I might hear more about that in a minute. Okay, so in summary, we've kind of just floated around a few different things. It is difficult, and it is challenging, especially when we're not doing it every day as a team. And for those of you guys that are in the lab, if we're a bit rude to you sometimes it's because we're a bit scared and stressed by what we see in front of us. I can't obviously emphasise, with my simulation hat on, I can't emphasise enough the multidisciplinary nature of it all. It's such a good example of how we need to work in teams. And just for the Western Sussex people, there's a lot of antenatal guys here. They should be doing the bookings. Thursday, Friday, fine. Okay. Did I overemphasise that? Thank you.